Very good morning. Welcome to another episode of Health AI Institute's webinar with Dr. Eric Poon, moderated by Gopal Khanna.
Thank you, Ikram. Appreciate it. And good morning and welcome to all of you who've been able to join us from within the United States as well as overseas. We're really honored and pleased to have with us Dr. Eric Poon, who has an extensive background, and we have made it available online so you can see. I'm going to summarize some of his key things and interests. Dr. Poon is the Chief Health Information Officer for Duke Medicine. He's also a practicing physician. He's an internist and works extensively with the patients, providers, and being at the university with educators as well. Dr. Poon attended Harvard Medical School. He's also contributed hugely to academic papers as well as conference papers, articles that have been published, worked at Brigham and Women's Hospital in Massachusetts. He comes with a very distinguished background, and we are really pleased to have him this morning, particularly because of his interest in IT innovation. He heads the visioning and strategic planning with physicians, researchers, and colleagues at Duke. So, Eric, we are pleased to have you here with us this morning. The virtual floor is all yours. Please take it from here.
Great, Gopal and Ikram, thank you for the generous introduction, and thank you so much for inviting me to share with you some of our experience in implementing AI in 2024. So let me share my screen and then put this in presentation mode. So I always have to ask the question, am I showing the right screen or do I need to switch?
Yeah, good.
Okay, great. Yes, so I have tongue-in-cheek entitled this talk, Déjà Vu. What are some of the things that we have learned from electronic health record implementation that we should bring forward and apply in the brave new world of generative AI? So just to provide some context, I think you need to be living under a rock in the last 2 years to not know about all the impact generative AI has had on society in general. So as you may recall, ChatGPT was released by OpenAI in November of 2022. It's only been just over 2 years. And on the left here, I am showing how various technologies, including ChatGPT, attained 100 million users over the world. Household names like Uber took 70 months, Pinterest took 41, and ChatGPT took all of 2 months. So certainly qualitatively different than other technologies we have seen. And on the right here, and this is already fairly old data, shows the performance of GPT-4 in scoring various standardized tests, ranging from LSAT, SAT, GRE, and medical knowledge self-assessment program, and advanced placement. And as you can see here, GPT-4, this is year-old data, was giving a lot of people a run for the money in terms of standardized test performance. Present company except of course. And of course, a lot of organizations, including Duke Health, where I work, has really put a lot of stock in what generative AI could do for us. And what I'm showing here in a bit of an eye chart is the summary as of a few months ago in terms of all the various generative AI projects that we have been taking on. The point here isn't the individual projects. The point is that there's just a lot of promise and a lot of activities. And that is not just reflective of the level of interest and enthusiasm in large organizations such as Duke Health, it's also reflected in the amount of investment that is in the generative AI space. And I can tell from attending conferences over the last 2 years that there's something qualitatively different about generative AI in that the pace of change, even for somebody like me, is hard to keep up. I really feel that there is a lot coming, and the pace of innovation is only increasing. So in some ways, it's very exciting for folks. But I think as we are embarking on this new era, I thought it would be helpful for us to look in the past and see what we can learn. And I will walk you down memory lane to uh, wow, I'm doing my math to back to January 2009 when President Obama, look at how young he looked at that point, uh, was inaugurated in the context of the financial meltdown brought on by Lehman Brothers in 2008. And as part of the American Recovery and Reinvestment Act, the HITECH Act was passed. And President Obama talked about it in his first presidential address on the radio. Uh, and he said that he part of the HITECH Act was to lower overall healthcare costs, cut medical errors, and improve care by computerizing the nation's health records, which at that time was mostly paper-based. And he anticipates that that will save billions of dollars in healthcare costs and countless lives. And since then, on the right here, you will see that the use of electronic health records has gone from a tool used by isolated organizations to being nearly ubiquitous in the US. And this is a rapid transformation by all stretches. And many of us have been part of this change. Uh, Members of the audience who were using or were practicing healthcare in any way, shape, or form during the last 10, 15 years would have been part of this change. And I would ask everyone to tap into our collective trauma because everybody I've talked with uh, at organizations has a story to tell about the amount of change the electronic health record has brought onto all of us in terms of our workflow, how we interacted with patients, how it has, on the one hand, facilitated information access and made some aspects of care easy and safer, while on the other has been very disruptive, and the transition has been by no means easy. And this has been imposed on almost everyone practicing healthcare in the US. So in thinking about what we can learn from the past 10, 15 years in terms of electronic health record implementation, it's important to understand and bear in mind what things are similar now compared to the last 15 years and what's different. So let's think about things are similar now compared to the electronic health record implementation. I think first and foremost, it's important for us to acknowledge that the target of electronic health records is human decision making and human behavior change, be it on the part of clinicians or patients. That is not different in AI. And that really drives much of the rest of today's discussion, that observation. I would say that the impetus behind the HITECH Act was improving patient safety and quality. And I think today that still remains a key driver, as you may have read from my mentor, David Bates, who published in the New England Journal. Patient safety is as acute and significant of an issue today as opposed to 20 years ago. And similar to the EHR implementation era, AI is being rolled out, guess what, in the real world where resources remain finite. With every piece of technology that gets rolled out, AI or not, you need to think about the total cost of ownership, how you support it, keep it going, and how individual organizations decide what the smorgasbord of technology would be picked from at any one point in time. And then, like the challenges we've been facing in technology over the last 10, 15 years, cybersecurity and patient privacy concerns are still top of mind as we walk into the generative AI era. So what's different? now compared to 10, 15 years ago. As I was alluding to, we've had challenges in healthcare, but they seem bigger today in the aftermath of the pandemic. There's still a lot of demand for healthcare services as the population ages and as patients' expectations rises. However, the inflation globally has really ratcheted up the costs in delivery of healthcare, and the feeling of burnout brought on by the pandemic certainly has made it harder to keep colleagues around, and that in part has contributed to the rising costs in healthcare. So that, I think, are some of the challenges we need to bear in mind as we walk into the generative AI era. And of course, what's different is that generative AI has excited so many industries and so many people, and you can't walk into any conference without every single booth having the title AI somewhere in there. And um, the and as we work with various large vendors such as Epic or some of the newcomers like a Bridge or Nuance providing ambient notes technology, you will see that they are working fast and furious in providing new features in AI and in many cases generative AI. And so what I'm showing here are two of the roadmaps from the two companies, slightly obscure to protect the intellectual property, but certainly lots of things happening. And the analogy that I have drawn from my past experience in implementing technology is that just like uh, any form of health information technology, a lot of things that could work, should work, don't end up working for a variety of technological and, more importantly, sociological reasons. In other words, uh, I tell my team tongue in cheek that with AI, just with any technology, you need to kiss a lot of frogs in order to find your prince or princess. So, but what's different today is that we have a lot more frogs coming down the pipeline. So you can imagine yourself sitting in the front porch and you have all these frogs hopping along in your front yard. Some of them can be magical, but some of them can be poisonous. And our job in in our respective roles in our organization is to help ourselves figure out which ones of these frogs do we pick up. And when we pick them up, we need to efficiently try to kiss them. And most importantly, when we find that any particular frog doesn't have the magical powers to transform itself into a prince or princess, we'll let it go. Um, and while this is a bit of a silly analogy, I think this whole notion of us becoming more agile so that we fail fast with new technology is something that we all need to think about embracing. And then other things are different. I already alluded to the influx of venture capital investments flowing into AI. So that's driving up the number of frogs that are hopping in front of our front yard. I do want to point out that compared to electronic health records implementation, implementing AI may be a little easier because as organizations change from paper to electronic, it was very difficult to have hybrid systems. Hybrid systems, part paper, part electronic, actually probably creates more problems than they solved. So most organizations needed to go through electronic health records in Big Bang and have many parts of the organizations going live at once. Whereas I think now that we have a platform of electronic health record to work from, I think AI can be inserted strategically into discrete parts of the workflow on a more voluntary basis. So that gives us a little bit more flexibility in today's AI era. And I think you may disagree with the last point, but I do think that as I compare healthcare technology now to other industries, I find less of a gap. Healthcare used to be so behind airline and the entertainment industry, and healthcare is more or less caught up, although not fully. But of course, the expectations are higher from both our clinical colleagues and patients as they expect healthcare to work just as well as other parts of their lives. And what's also different about AI in healthcare specifically is that there are risks inherent in deploying AI in the healthcare industry. I think all of us who use AI in our daily lives, for example, by noticing recommendations from Netflix or Amazon, know that we can either take their recommendations or not, and nothing bad happens if we ignore the stars or the recommendations. But in healthcare, recommendations from AI tools have higher stakes in that if you keep generating alerts or recommendations are non-actionable, folks could get disenchanted and start ignoring everything that the computer tells them to. Worse, those recommendations could be biased. We know that a lot of AI is generated from data collected in the past, and if our practices in the past, as captured by the data, had biases, then AI could perpetuate those biases. We know from the electronic health record era that not every clinician would embrace the technology wholeheartedly. So you can put something out there, it doesn't mean it will be used. Or worse, if folks start using them, they can use it as a substitute for critical thinking, and they can blindly follow the recommendations, and that itself can create risks. And then one thing that we worry about a lot is that you can deploy all the technology in the world. It may not move the needle in terms of patient outcomes or patient satisfaction. It may not make the current state better. And I think having a clear-eyed view of what the technology is doing, and if it's not actually improving things in a meaningful way, we need to say goodbye. And for those of us who have been in the technology space for a long time, know that technology can malfunction, and you need to plan for that. We've had AI algorithms start recommending nonsensical things because the inputs change, because the lab all of a sudden started reporting a particular lab in a different format. And of course, the regulatory space is fast moving and is changing. We worry about what the FDA might do. Would these AI tools be classified as medical devices? And I think a lot of questions remain unanswered. So with all that background in mind, I would like to suggest a few lessons from the past that we can use to help us use AI in smarter ways. And I think first and foremost, we need to respect the human factors in thinking about AI. And because, as I mentioned before, AI is trying to change behavior, trying to change decision making. And we've had decades of experience in thinking about how technology can influence decision making. On the left here, I have summarized the 5 rights of decision support, which says that if you want to use information technology to influence decision making, you need to provide the right information to the right recipients through the right channels in the right format at the right time. I think that's an oldie and goodie that should stay with us. And I've seen far too often that people hear that AI is coming and they put the AI tools into the workflow without thinking through the 5 rights, and inevitably they will fail. And of course, in order to make AI succeed, you really need to co-design it with the end user in mind. And a good framework is human-centered design, where you actually start with observing in the real world how things get done and understanding the problems uh, that you are trying to solve, and then working with end users to design the solution, prototype it, iterate, fail fast, and test it in the real world in order to make sure that the technology is actually useful. I think that principle will apply very well in the world of AI. And then another set of lessons that we would bring forward is the art of change management. Now, there's been a lot of books written about change management. My favorite one is the book Switch from the Heath brothers, who happen to be at Duke, although I actually don't know them personally. I read this book long before I came to Duke 10 years ago. And what the Heath brothers talk about is that in order for us to be effective at introducing change, you need to think about how to make change easy. And their analogy that they draw is that in order to change people's behavior, you need to really address three main things. They draw an analogy between the human mind and um, a a rider riding an elephant. The rider on the elephant is analytical, knows where he or she might want to go, but is physically weak. Whereas the elephant, once the elephant gets going, it will charge ahead and knock down a lot of barriers, but it may not be as smart as the rider. So in order to make change stick, you need to work with a human mind uh, in a rational way, and you need to talk about the bright spots, help your recipients and stakeholders understand what's working well today, and then help your constituents get started by scripting the first few set of moves and make those instructions extremely clear. And then as you get started, let people know very clearly where you're going with the change. And then in order to motivate the elephant, you really need to tap into people's emotional self, really have your constituents tap into the emotional connection with the change so that they understand the why, so that they make it personal. And you need to also make the change easier by shrinking the change and breaking it into manageable steps. And then grow your stakeholders by giving them the confidence to actually take on the change one step at a time. And then beyond working with the rational mind and the emotional mind, you also need to shape the environment and make the change easier by removing obstacles, building in habits and routines, and then using social influence to rally the herd. And of course, as you put in the change, you need to really watch how things are going and learn and adjust as you go. And for the clinical leaders amongst the audience, I think you have a special role to play because in implementing change in the clinical setting, clinical leadership actually makes or breaks the whole process because clinical leaders need to assess for themselves and their colleagues in a realistic way the level of readiness for change. Um, and in order to do that, the clinical leader needs to know the spectrum of personalities and know when is the right time to actually implement the change. For example, when there are a lot of other things distracting the organization, that may not be the best time. And as you embark on the change journey, the clinical leader needs to set the appropriate expectations. There is this joke in my world with EHR implementation that the new EHR is going to come and solve every single problem, and that is a recipe for disaster. So with AI, you need to make sure that folks understand that as amazing as AI is, it's capable of making mistakes, and we need to make sure that there's human in the loop so that we use AI responsibly. So that's one way of managing appropriate expectations. And as I mentioned before, engaging your clinical colleagues in designing the solution and figuring out how to roll it out and how to support it long term, and making sure that there are the right resources in terms of people and materials and knowledge and know-how to make the change a success. And of course, things don't happen the way you expect them to, and that's where clinical leaders serve an important role in being the key channel of communication in playing the translator between the technology team and the intended clinical users so that folks can learn and adjust along the way. And of course, clinical leaders need to walk and talk the talk by using the technology and providing feedback and demonstrating that sensible change can be made. And so these are some of the things that I have found to be really helpful for all of us to bear in mind. And for those of us who've been in this role, I would say that it's often challenging to take on these new challenges, but know that your senior colleagues in the clinical organization really have your back, because we all know how hard it is to implement change, and having somebody locally who understand the culture, who can secure operational buy-in, is really worth the investment and trust that senior leadership put in us. So make sure that we all leverage that when we can. And of course, there's a lot of hype with any new technology, and generative AI is no different. I think we are just past the peak of inflated expectations now, and some of us may be getting a little disillusioned that AI is not going to solve all our problems. And I think part of what I'm showing with the Gartner hype cycle is that we want to accelerate the slope of enlightenment as folks get comfortable with the technology so that we can reach the plateau of productivity more quickly with generative AI. And I would posit that the way to do it is to ask the critical question: is the addition of AI better than the human being taking care of patients alone? And that is a question that should be asked early and often, and the answer may not be yes all the time. Which brings me to the need for an organizational governance approach, because there will always be more solutions than any organization can have the human or financial resources to take on. So you need to be smart about what you take on, which frogs you kiss, and which frogs to keep in your pocket. And one way to do this is to make sure that the decision-making body has some clear guidelines and clear principles, and that the decision-making bodies are aligned with organizational priorities. Yes, you do need to pick wisely. At the end of the day, outcomes do matter, and you need to think about the long-term cost of ownership across the different stakeholders. And make sure that the technology is not just turned on and left on indefinitely. You really need to make sure that the organization is ready to take on the technology and ensure its success. And if it's not working, turn it off. And of course, there will be resistance. And what governance bodies do, at least when they do it well, is that they can help the project teams identify resistance early and help them overcome them by restating the why behind the technology in public forums in a strong way. And of course, these governance bodies need to hold the project teams accountable for setting realistic targets for outcomes that they can achieve and demonstrate. And nothing is a set it and forget it when it comes to technology, and AI is no exception. I would say that this is where I think we have not done very well with electronic health records, in that we turn on electronic health records and expect it to run itself. And I think that's a recipe for failure. One strategy I would advise everybody to adopt more broadly is the commitment to measuring impact as a way to turn things off if a pilot is not successful. In our world, we talk about pilotitis, meaning that there could be lots of technologies that are in pilot mode but never get scaled up. You need to cut your losses if things are not working so that you can create the headroom and the resources to try new things. And then there is always ongoing care and feeding of all technologies. Think about order sets that get updated, um, pop-up prompts that may not be effective, that are still draining the mental energies of its intended users. So those are things that need to be groomed forever. And then new things come along with technology. There are always new features, new releases, and ongoing training is something that we all need to think about. And we've also learned from the EHR era that there are unintended consequences to implementing technology. AI is going to be no different, and we have a responsibility at the dawn of the generative AI era to think about how we might become over reliant on these new technologies. Sometimes it might be good for us to think about not using it once in a while so that we know what to do if it's not available for any technical reasons, and for us to really think about what we're gaining from this technology. There are always workarounds that can thwart the underlying purpose of this technology and actually introduce new risks. That's something that we, as informatics and clinical leaders, always need to be on the watch out for, such as things like alert fatigue. And just as an example, we have set up at Duke a just-in-time AI oversight process, which we fondly call algorithm-based clinical decision support. I know that's a mouthful, but we call it ABCDS for short, and that rolls off the tongue. And in many ways, we decided that AI governance is not a once and done deal. We provide just-in-time approval and guidance to project teams as you see on the right, as the AI projects go through the different stages of the initial silent evaluation, and then when they're ready to deploy it, we ask them to measure impact and bring back the results, and then commit to whether they want to continue to use the technology or whether that needs to be turned off. And then on an ongoing way, represented by the small green diamonds under the letter G, M for maintenance, they need to come back and tell us how they are watching the usage and whether there's any drift in terms of workflows or underlying performance of these AI tools. So that's a paradigm that we've been using to govern more than 80 of our AI tools, both traditional predictive models and some of the new generative AI models coming at us from our vendors, from internal developers, all go through this particular paradigm. And one important element for us to think about as we are still early on in the journey for generative AI is how do we prepare our clinical colleagues in the front lines to get ready for this new technology? And I don't think I have the answer, but I think introducing all our clinical colleagues to AI for some low risk tasks, such as using ChatGPT or Microsoft Copilot to rewrite some of our emails, to plan our parties, or to just get ourselves organized, could be a good way for them, for all our colleagues to understand what AI can do and what its limitations are. I do think that along the way, we need to reinforce every clinician's role as critical thinkers and continue to motivate them by aligning the technology with the reasons why they got into clinical care in the first place. And then some of the things to emphasize is everybody's desire for professional autonomy, mastery of the art of clinical care, and the purpose behind why they are in this business. And with new technology comes lots of opportunities. So I think creating the organizational capacity to embrace new ways of doing things is something that we should be doing with or without technology. I think encouraging a growth mindset so that folks understand that the way we have done things may not be the way we do things moving forward. And then with new technologies, we'll bring new knowledge and new responsibilities and new way to better serve the patients that we care for are some of the things that we need to remind each other from time to time. And I do think that there are still lots of unanswered questions when it comes to generative AI. One example, we're now rolling out ambient technology in my organization to all our attending level and advanced practice providers. The question has come up with that we haven't answered. At what point is it reasonable to let our medical students and residents and fellows use that technology as they see patients? Would love to hear if folks have any thoughts about that. But that is just one of many examples where technology is going to challenge us to do things different now, and then things that we used to cherish may take a lesser role. I think of my middle school daughter, who's 12 years old now, spent probably a month learning cursive, and that's probably pretty generous of the school. Whereas I spent a lot of years in my grade school learning cursive. That's less important now. But so we all will need to think about learning new skills because the world that we live in now is going to evolve and change. And it's so exciting to be going on this journey with all of you. And this is a great time for me to pause and to ask everyone, what else should we consider as we walk into this era of generative AI, as new technologies will challenge us to be creative in thinking about how we can do things differently? Uh, and I look forward to the Q&A session and encourage folks to submit questions online. And before we do that, just want to acknowledge my dear colleague, Tejo Gandhi, with whom I did quite a bit of brainstorming to come up with this talk. And we are actually writing it up for a journal. So thank you. Let me undo the.
Yeah, it's yeah.
Okay, you guys are still here.
Yeah.
But thank you, Eric. That was a pretty powerful presentation, very extensive, very wholesome. You've covered a lot of ground, and I'm sure our audience would definitely benefit from it. I do, maybe for starters, Ikram, if it's okay, let me ask a couple of questions.
Yeah, Gopal, please go
One
ahead.
thing you did not cover, Eric, or maybe you did and I missed it, was funding. Lessons learned last time around. Again, you cited President Obama after that financial crisis. Enormous amount of funds were available from federal government to get the electronic health record systems into the systems. This could be just expensive or more expensive. Where do you see the funding situation addressed, particularly when delivery system CEOs are complaining and CFOs that the margins are shrinking in the system?
Oh, this is a great question. I live that every single day. Yes, I do live in the real world as well. Things are challenging, and I don't think there's going to be another meaningful use program coming our way to promote the use of AI. I do think this is where we have a special responsibility to come up with the uh, the infrastructure, the human infrastructure, uh, for us to try new things in low cost, low risk ways, um, and demonstrating outcomes so that we can bring those results to our leaders so that they can make the appropriate investments. Now, this is not theoretical. This is exactly what we did with ambient technology. And we tried it out with some folks and saw a lot of promise, but wasn't sure how it was going to scale in terms of whether it will work across different specialties, and then did a much larger pilot with some modest costs to for 160 providers, got really positive comments and convinced our clinical leaders that that this technology has some real potential to increase productivity. And you don't need to increase productivity by a lot in order to pay for it. That's how we got the investment made. And and there is no magic to it. Some of it is really about trying things and bringing results to the table.
So, Eric, basically what I'm hearing is that the industry cannot count on federal funding.
I don't,
the way it was
not
done.
that I can predict what the new
Okay.
administration is going to do, but
But yeah, one cannot count. So leaders, maybe they have to, do they have to think differently? Uh, did the whole business process re-engineering come into play? because when new technologies come in, at least in the industrial world, an effort is made to redesign the business processes as opposed to taking new technologies and just making them available and retrofitting a new technology with all the old processes and requirements. So, what are you seeing in terms of efforts, or are there things that can be done? Maybe that's the question. Are there things that leaders, CFOs, CEOs, the boardroom can sort of focus on and say, why don't we use Deming methodology or tools that can help us with re-engineering of the business processes? In the last
Yeah,
investment, very few hospital systems re-engineered. Only
yeah,
a few went out of the way and said, "What's the industry doing?"
yeah. I think my perspective is rather than waiting for the perfect approach to emerge, we should get started. I do agree with you that it is all too easy to throw technology into a traditional process and hoping that it will lead to better outcomes because they rarely do. When technology is implemented without the necessary hard work to redesign how we do things. And in some ways, it's a chicken and egg problem because without the technology to enable new ways of doing things, you can't move people from the current state. But even with new technology, I would point out the fact that it still takes a lot of energy and change management and leadership to get folks to embrace um, the new ways of doing things in a consistent and structured way and in an ongoing manner. The commitment to actually do that is often absent in healthcare. So, which is why we set up the governance process the way we did. Not that it's magical. We don't have magical criteria for looking at AI, but I have seen all too often at my organization and in my previous organizations with technology being introduced and unclear benefits. They might tell a good story up front when they're going up for approval, but down the road we look at them and say, has it made any difference apart from a new app that is now being pulled up from time to time? Um, those questions remain more often than not unanswered.
Mhm. So, given the fact that it's a demand and supply situation, the demand for new technologies, what it can do is rising, and you're seeing with the burnout, enormous amount of clinicians leaving the business, and overall there's a 20 million doctors and clinicians shortage worldwide. So, given some of these constraints and realities, um, what kind of challenge does it pose for the CEOs in the healthcare delivery systems? What do they have to think
Yeah.
about?
Yeah. I do think that I think organizational leaders need to create the environment for folks to have some headspace, have the
Mhm.
mental energies to try new things as part of the culture. And because if folks insist that they have to do things the way they always have, nothing is going to change.
Mhm.
And I do think if there's one thing I've learned from the EHR era in the last 10, 15 years is that the change management is so much harder than the technology itself.
Mhm. And that's because people are resistant to change. People
I
just
think
want.
part of it is people's resistance to change, but I don't want to just blame it on people. I think
Yeah.
one thing that we have learned in the EHR era is that nobody actually, in many cases, understand what the underlying process was. There
Yeah.
might be 15 ways within a single practice of doing things, and people tolerate it and they make do. And when you put in a new technology and you think that it's going to be used for everybody's benefit in one way, and then people try to bring their own preconceived notions and workflow habits in, and things break down and errors occur. We've seen that way too often with electronic health records. And having the local leadership to really think about what are people really doing today to do the work, and understanding, getting buy-in from everyone that they are going to adapt the workflow in the context of the problem they're trying to solve and the new technology they're going to be bringing in. That takes time and effort. And to my earlier point about EHR implementation being big bang, one of the prices we paid for big bang implementation was that there was not enough time and energy devoted to this change management. We really, for many reasons, decided to just slam the technology and deal with the change management. And that's an important thing that we should be careful about not repeating as we walk into the generative AI era.
Now, one of the things, Eric, changing subjects is moving from technology is bothered the physicians and clinicians and delivery systems is the evolution of what I call the measurement industrial complex. That there's so much of measurement that is going on that people are tired of part of the burden on the practice is the measures that have been created. How do you see that space evolving or changing? Because they too would have to think about change as to what measures are good.
Yeah, I think our Chief Quality Officer, Dr. Rick Shannon, talks about the tyranny of measurement, and I'm very fond of the saying, which is an African saying, "Weighing the cow doesn't make it fatter."
Yeah.
And so I think this actually ties in with what the point I was making earlier. Yes, you can't manage what you don't measure. That is true.
Yeah.
But you're not going to change everything by measurement. And in many cases, electronic health records made it easier for us to measure certain things, and that's not bad in and of itself. But having those measures flashed up in front of everyone every minute, every hour is not going to really move the needle in terms of better satisfaction outcomes. You really need to create the environment and think about how people would react to those dashboards, no different from any other aspect of decision support. You really need to spend the time and energies and to explain to people how they're going to use the data, why they should be doing this, and how to encourage folks to get comfortable and embrace it as part of the new way of doing things. And that cannot be done overnight.
Yeah. Ikram, I want to pass it on to you if you have any questions over there. I know you've been collecting some, and if you want to summarize and talk about them.
Yeah, Gopal, thanks. I think that great and very, very important talk, Eric. I think there's a lot of interest on this topic, and we have received a lot of questions. And I will see that's how much time we have and how much we can cover it. So you mentioned in one of your slides that what risk could be deploying AI in healthcare, and one you said that it can offer biased recommendations for the clinicians to take on. So, what way you think that you as a leader in the organization you were thinking while deploying any AI solution that it should not further exaggerate the way the health system is already biased with whatever data and the way the clinical decision support system is there.
Yeah, I mean, I think this is certainly a challenge. The way we are addressing bias is through our governance process. We ask especially for predictive algorithms that come forward, we ask them to look across different demographic groups to see if the recommendations are less accurate for certain groups. So subgroup analyses are helpful. And then we also want them to kind of think about end-to-end whether the use of those recommendations would somehow lead to exacerbation of inequities. I mean, I think the question isn't how can we eliminate inequities. We wish we could do that, but I think the more practical approach is how can we be made aware of potential ways that technology could exacerbate inequity and be proactive in managing it. So, for example, if we find that, and we've done that with some of our predictive AI algorithms, if we find that the among certain gender or racial groups that um, the thresholds for alerting may need to be adjusted so that we don't inadvertently bias care against certain groups. I think that's something that it's a conversation that we need to have with folks who are bringing forward these solutions.
Great. I think that's what we are hearing, that system big as
Yeah.
Duke and big healthcare system can have resources to fix it, but these challenges can be big for a smaller health system who don't have resources to go for all the kind of AI algorithm which they are thinking of deploying into their system. So the challenge would be much bigger and very different for them in their case.
I think this is a challenge for all of us. We don't have the resources that we would like to have, honestly, at Duke Health. I think quality is more important than quantity here.
Mhm.
I think that it's very easy to bring some technology on board just to say that you've done it. It's another thing to be thoughtful about it. So if an organization can only take on 2 or 3 new AI technologies, that's okay. Or even if you can do one, make sure that you are thoughtful about this. Do some measurement. It doesn't need to be publication quality measurements, but at least think about usage and adoption and think about any surrogate outcomes that you can measure using tools like survey tools. Those are things that we should be able to do fairly easily. The question is, do you have the discipline to actually make the project teams accountable? Because, and I've been on the other end of the equation, a lot of times we're under pressure to bring a piece of technology into production, get into the hands of clinicians, and then we are very busy. We're behind on other projects, so our attention gets directed away from the thing that we just implemented, and we don't come back and look at it. And that's what we need. I think that we need all ranks of leadership to guard against.
Great. I think in the follow-up to this question, we have another question which you mentioned about the committee, governance committee. That's a very good idea to involve all the stakeholders to get the buy-in, and good to hear from you that which way your governance committee, which is ABCDE, that's easy to remember, how you take the decision that which tool, as you were mentioning that 2 or 3 tools, might be you have exposure or offer of 1,000, and then how you try to select that, which tools you are going to use and recommend to the senior management.
Yeah, so this is part art, part science, and it really depends on the capacity of the organization. I think the principle that I would share that I think will be applicable to everyone is that one thing the governance committee can do is to make sure that each project, each proposal that comes forward is actually resourced for success, and to point out if they are not. Because a lot of folks may be enthusiastic about technologies and they don't think about the downstream implications in terms of both technology and people and long-term maintenance. And if you see that the project team has not thought through the issues, we need to point it out to them so that we don't end up having them go down rabbit holes from which they will never exit.
Thank you, Eric. I think we are close to our time, and before that, like to go back to Eric and hearing his thought his final thought about when we are entering into this Gen AI era. And in healthcare, which have been quite behind, as you said, the financials and entertainment industry, how you see and suggest the leader in this industry to be managing and thinking about involving this technology in new era?
Well, I think the possibilities are quite literally endless. I think that we all have a responsibility to be creative in thinking through the art of the possible, and then uh, bringing those solutions to the table and helping folks understand how to use the technology responsibly. I think it is not one person or one role per organization. It's really a team effort. So look forward to learning from all of you as to how to steer society through this new era.
Great. And I look forward to hearing Gopal's thought.
Well, a fabulous presentation, Eric. So thank you so much for taking the time to be with us this morning. I do have some more questions, and maybe I'll drop you a note and would continue this conversation with you offline. Uh, I must thank you and thank our audience to be joining us this morning, both within the States and overseas. This has been a delightful conversation. I hope you people have benefited from it just as much as I have. I have some newfound understanding. I understand the lessons learned from the past and how we can be better prepared for AI implementation. I think Eric is absolutely right when he says that we have to be cautious, but at the same time be optimistic because technology can help. And I think so. The third point that comes to my mind is, Eric, the fact that there has to be strong support from the senior leadership, CFOs, CEOs, and the boards will have to support because healthcare sector cannot lag behind the industry in terms of use of AI and the possibilities it offers. So again, Eric, thank you so much for joining us. Really appreciate it. Thank you, Ikram. I think we have a minute or two, so maybe people buy themselves an extra minute, unless you have anybody else has any thoughts. Eric,
Yeah,
one more last chance.
just to add to Eric, and I think we'll be following up. We are hosting here Healthcare and Life Sciences AI Summit in June 10th and 11th, and we'll be following up with you. Tejal is very co-part in organizing that, and she recommended greatly about, and it's great hearing you, and we might love to be inviting you here and hearing and sharing your thoughts and knowledge with wider audience here.
Oh, happy to help. Well,
Okay,
thank you so much for having me.
thank you.
Okay,
Thank you
bye-bye.
all.